All right, welcome everyone. Today, we're going to tackle a super common clinical problem, the incidental liver lesion. You are going to see this constantly, so our goal here is to build a really solid mental map, a framework you can use to confidently work up these cases, right from that first scan all the way to a final diagnosis.
Okay, let's just jump right into it with a classic scenario. You get a call. It's about your 55-year-old patient with cirrhosis who was in for a routine ultrasound, and boom, there's a new 3-centimeter lesion. So, what's going through your head? What are the alarm bells? And most importantly, what are you going to do next? This is the exact kind of question we're going to break down.
So, here's our game plan. We're going to follow the path of a logical workup. We'll kick things off with the common benign tumors, the ones you don't want to miss. Then, we'll do a deep dive into the big one, hepatocellular carcinoma, or HCC. We'll touch on a few other malignancies, and then wrap it all up with a practical algorithm you can actually use on your next shift.
You know, with CTs and MRIs being ordered for just about everything these days, we are finding these incidental liver spots all the time. They're everywhere. So the real challenge isn't finding them, it's figuring out what to do about them. Having a systematic approach is absolutely crucial to avoid causing unnecessary stress for the patient, while also making sure you don't miss something serious.
So, where do we start? Well, before we jump to the C word, you have to know the common benign players inside and out. Seriously, being able to recognize their classic features can save your patient a ton of worry and a whole lot of unnecessary procedures.
This is a great way to think about it. We're building two distinct pictures here. First, you've got the hemangioma. Just think of it as a benign tangle of blood vessels. That's why in imaging, you see this classic slow peripheral nodular enhancement. The contrast is just slowly working its way through that tangled web. Then, on the other hand, you have the hepatocellular adenoma, or HCA. Your spidey sense for this one should be tingling in a woman over 30, especially if she has a long history of oral contraceptive use. And the first step in management? It's often as simple as stopping the OCPs.
And rounding out our top 3 benign players is FNH, or focal nodular hyperplasia. The one thing to really lock in for FNH is that central scar you'll hear radiologists talk about. It's a classic buzzword that really helps point you in this direction, especially when you see it in a patient who's otherwise totally healthy and has no cirrhosis.
Okay, now for the one we just can't afford to miss, hepatocellular carcinoma. HCC is by far the most common primary liver cancer. And what's critical to remember is that its diagnosis and management are totally intertwined with underlying liver disease. In a patient with cirrhosis, a new liver lesion is HCC until proven otherwise. Period. This is exactly why we're so proactive. We don't just wait for symptoms to show up. The standard of care is an ultrasound every 6 months for every single patient with cirrhosis and also for some high-risk folks with chronic Hep B. The goal is simple, right? We want to find these things when they're small, when we actually have a shot at a cure.
So, this brings us to a massively important tool called LIRADS. The best way to think about this is as the special language radiologists use to talk about liver lesions in these high-risk patients. It's a standardized system that uses a multiphasic CT or MRI. That just means they take pictures at different times after giving IV contrast. It lets them look for key features like how quickly it lights up and then washes out, which can let us diagnose HCC with incredible confidence, often without ever needing a biopsy.
And this is the LIRADS pathway in a nutshell. It's really just a spectrum of risk. LR1, definitely benign. We can all relax and just go back to routine screening. LR3 is kind of in the middle, so we're going to watch it a bit more closely. Now, LR4, that means we're getting worried. This is a case you bring to a tumor board and you're seriously thinking about a biopsy. And then you get to LR5.
This is the money quote. This is the whole point. In a high-risk patient, if a lesion meets the strict imaging criteria for LR5, that is diagnostic of HCC. I'm going to say that again. You do not need a biopsy. The diagnosis is made on the scan alone. It's time to manage this as a cancer. This is a huge practice-changing concept.
Now, while HCC is the most common horse in this race, we have to keep a few zebras on our differential diagnosis. These are less common, for sure, but they can be tricky and they often need a completely different management plan.
A perfect example of a zebra is fibrolamellar HCC. Just look at this table. It's pretty much the mirror opposite of classic HCC. We're thinking about a young patient, someone under 35 who doesn't have cirrhosis. Their AFP tumor marker is normal, and the imaging is different too. You might see a big mass with a central scar. Wait, central scar? Didn't we just hear that for FNH? This is exactly why the whole clinical picture is so critical. It's a totally different story.
Another important one to keep on your radar is intrahepatic cholangiocarcinoma, or ICC. This is a cancer of the bile ducts inside the liver. Key risk factors include things like PSC. The presentation can be really vague: dull pain, weight loss. And here's the key difference from what we just learned about HCC. Unlike an LR5 lesion, the diagnosis of ICC almost always requires a biopsy for confirmation.
Okay, we've covered a lot of ground, so let's put it all together into an actionable plan that you can use the next time you get that page about a new liver lesion.
First off, a critical reminder. The alpha-fetoprotein, or AFP blood test, is really tempting to order, but please remember, it is not a diagnostic test for HCC. It just isn't specific enough. Your diagnosis is going to hinge on getting high-quality multiphasic imaging, so don't let a normal AFP give you a false sense of security in a high-risk patient.
And here it is. This is your algorithm, your mental checklist. The very first question you ask is this a high-risk patient? If the answer is yes, they've got cirrhosis or chronic hep B, your brain should immediately jump to the LIRAD system. If the report comes back LR5, you treat it as HCC. If it's an LR4 or something else suspicious, it's time to talk to your colleagues at a tumor board and probably get a biopsy. Now, if it's a low-risk patient, you're looking for those classic benign features we talked about. If it looks like a textbook hemangioma and the patient feels fine, you can safely watch it. For pretty much everything else in that gray zone, a biopsy is often going to be the final step.
And let's end with a quick look to the future. With fatty liver disease, or NAFLD, becoming so common, we're starting to see more and more liver cancer in patients who don't have cirrhosis. So the big question for all of us is, how are our surveillance guidelines going to adapt to this new reality? It's a huge challenge and something we're all going to be dealing with in our careers. Definitely something to think about.